Thank you, Akhil. This was supposed to be Dr. Siddharth's talk. He has made the slides. So this is a predecessor trial, or probably the earlier trials where immunotherapy alone was tried. It was largely to see whether there was activity or they were safe enough. So, but now we have 5-year data from that trial, and hence it was presented as an abstract. So why there is a need, as everyone has told since morning, that even in early stage resectable lung cancer, after surgery and chemotherapy in needed patients, the risk of recurrence is very high, in the tunes of 33% in stage 1B, 51% in stage 2, and 61% in stage 3 as per LACE meta-analysis. And so we all know that we need to do something better. So in this study, neoadjuvant nivolumab was given in NSCLC, and here 5-year outcomes are presented. This was probably the first phase 1-2 trial where neoadjuvant nivo in resectable NSCLC was given, and it was shown to be safe and feasible in the first paper which was published. Now this is long-term survival data, probably the longest follow-up we have for any neoadjuvant immunotherapy. So here 2 doses of neoadjuvant nivolumab 3 mg per kg were given prior to resection in 21 patients with resectable NSCLC. 5-year follow-up data including recurrence-free survival, overall survival, and association with pathological response were tabulated. Event time distributions were estimated by Kaplan-Meier. All p-values are two-sided with 0.05 significance level. So newly diagnosed resectable stage 1 more than 2 cm, stage 2, stage 3 NSCLC were taken nivolumab 3 mg per kg for 2 cycles followed by surgery, and then standard of care post-operative treatment was given. Primary endpoint was safety and feasibility, which was reported prior. Tumor pathological response as per PD-L1 mutation burden were also reported. So we had major pathological response in 9 out of 20 patients who were resected, and responses occurred both in PD-L1 positive and PD-L1 negative patient. The forest plot, the waterfall plot shows the adeno, squamous, smoker, non-smoker. Most of them had response. There were 2 pathological CR. Now we have 5-year update after median follow-up of 63 months. Overall survival at 3 year is 85%, 4 year 80%, and 5 year it is 80%. Recurrence-free survival at 3 year is 65%, 4 year is 60%, and 5 year it is 60%. Hazard ratio for pathological downstaging tend to show improved recurrence-free survival. As the data set is very small, we can't comment on statistical significance because it is crossing, the confidence interval is crossing unity. And hazard ratio was also estimated for major pathological response, and they used different cutoff of 50% residual tumor and showed that hazard ratio. So it was 0.61 with MPR and 0.36 with the new cutoff of 50% residual tumor. The direction of effect of pre-treatment PD-L1 positivity was showing improvement in recurrence-free survival. Again, due to small size, confidence interval is crossing 1, but hazard ratio is 0.36. At 5-year follow-up, 8 out of 9 patients with major pathological response were alive, and no cancer deaths have occurred. Among patients with major pathological response, 1 patient recurred but was treated with definitive CTRT. Both patients with PET-CR are alive and without recurrence. There is no new long-term immune-mediated adverse event which have occurred other than 1 grade 3 dermatological event which was reported in prior paper also. So in conclusion, this just showed that those who benefited continued to gain benefit, and based on historical trend, it looked like this is a favorable thing. Now with Nivo plus chemo coming, I think single agent nivolumab, no one would be giving single agent nivolumab unless patient is absolutely unfit for chemotherapy, and such patient is unlikely to go for surgery also. Thank you.